So, as the title said, implant-supported prosthesis, the aim of this presentation is to talk about maintenance in the long run, in the long term. Because after the surgery, after we finished, we delivered the prosthesis in the mouth, everything works well in perfect conditions. But after a few years, or after many years in the decades that we are hope that our prostheses are going to live, many problems can occur, and we need new instruments to solve this problem. I invite you to write in the chat if you have questions, and Claudio will answer you immediately, or at the end of the presentation. If the answer is more complex, we will talk about any question you have. And so, more than 500,000 implants are placed each year by dentists in the USA. Let's look at some number just to begin, and to see how many implants are there in the mouth of our population, of the average population. 3 million people have received an implant in the USA so far. And 7 million implants, Brånemark-like type, these are the most studied implant type in the world, have now been in the literature, have now been placed, and hundreds of other companies produce implants nowadays. I can say that only in Bologna, in my town, the town where I live, there are 4 implant companies in the neighborhood. Try to imagine how many implant brands there are spread in the world, worldwide. What I want to say with this, I want to say that the patient's scenario is going to change. Our patients are no longer complete edentulous patients, but in the future, I see more partial edentulous patients and more patients with implants placed in the past decades. And past decades, I mean also 1980, since when the implantology became a more widely practiced discipline from dentistry, in the average dentistry. This means that we are not to treat any more patients because they are missing all of their teeth, or we are not treating any more decays. But our new pathologies will be related to implant, pre-existing implants in the mouth. And they can be subdivided into 2 types of problems. Pathology, I may say. Biological, and they are, of course, peri-implant mucositis and peri-implantitis. And these kind of problems have tons of literature review, and I invite you to go to that literature to go deep in this argument. What I want to talk about is more the mechanical problem, mechanical issues. And this could be divided in mostly two kind of problem: implant parts failure or prosthetic failure. And this is the focus of our presentation. And to solve these emerging new kind of problems, we need new tools. We need new tools for the maintenance in the long run, and also for in the case of renewal, old or worn out prosthesis over implant components or implant components. And so I think that this kind that you see right in the list, this will be our daily practice early in the future. The most common problem that we face is the unscrewing of the abutment. It's more easily found the unscrewing of the abutment in the single tooth. But it can occur also in a partial fixed denture or in a complete denture. And to solve this problem, REIN 83 can provide this kind of screw, and you can ask directly them. You can ask especially your own brand screw with this kind of shape inside, and a plastic insert that get inside this slot. The slot can be cut into your own brand screw, or in OT component, REIN 83 components. This plastic insert allow to give a more friction to your screw, and it doesn't unscrew anymore. This is a system provided by mechanical studies, and it guarantees you from unscrewing of the abutment. The second problem is when this especially occurs when you have removable denture with ball attachment or other kind of attachment that the patient doesn't take care for a long time of changing female caps, or doesn't take care. So you have an excessive wearing rate, you have a worn out attachment, and the female cap doesn't match anymore, doesn't clip, doesn't have any more retention as in the beginning. And to solve this problem, we have two ways to solve this problem. The solid reconstructive sphere, and it is exactly a completely new sphere, nitrurated, so it has the hardness of the nitruration. So it's 1,600 Vickers. It's the most hard surface for removable components. And it has in the bottom a pin that must be glued in a slot that you can produce by yourself, or you can find it in your old prosthesis. As an example, so we have one kit complete with two solid reconstructive sphere, two female cap, and a handle to place the solid sphere in its place perfectly. In this case, we've been lucky because we had a perfect slot attached to this, and the male component was completely lost by the patient. The expensive and alternative way to solve this problem would be to remove the crown, make a new fixed prosthesis with a new attachment and a new removable prosthesis. But if we want to practice a cheaper solution, and today I think that we will need more and more cheaper solution, we can, inside this slot, glue in the solid sphere inside. So putting the anaerobic cement inside the slot and putting the pin with retention inside the slot. And this is the final results. After we had perfectly placed the male and the attachment in the fixed part of the prosthesis, we can reline a new female cap, plastic cap over that. Another strange and weird solution, and from this point we couldn't be able to find any trace of what kind of implant was that, what components could we use to put another prosthesis over this kind of abutment. The solution we found was to take advantages of this space, of this slot inside this old abutment, and put new solid sphere over that. And so we converted this old attachment in a perfectly brand new, in three perfectly brand new attachment. And we relined over that the old prosthesis of the patient. So with a very cheap solution, without making any surgery or invasive procedure, we renewed an old attachment, this old attachment. Also, this system can work with with a millet bar. This millet bar worked in the first year of its life because of the friction this bar had with the counter bar. But during the years, it lost completely friction. So to make new friction point, we added two more solid reconstructive sphere. And as you see, here is the pin with the retention that gets into the slot that I produced into the bar. Another way to solve this kind of problem is to use the hollow reconstructive sphere. It's almost the same concept of before, but this time we have a sphere that is completely empty inside. The surface is always the same, so nitrurated, so 1,600 beakers of hardness. And this time we use this kind of attachment provided with a kit. So we have also always the two hollow reconstructive sphere with the female cap, the holder, because it's a very small component, so we need the holder to handle these small components, and to fix a completely worn out ball attachment. This was an old implant, and this retention was a gold cast components, and it was cemented inside the implant. So it was impossible to remove this from the implant and make a new attachment. The solution we found was to drill a little bit more the head of the ball until it can fit comfortably inside the empty, the hollow sphere. Once it gets inside, you have to check it before. Once it gets inside and run till the end, there is no gap, so between the sphere and the head of the attachment, and there is a small space for the glue, for the cement. Then we can put the cement inside so there is the perfect fit between the hollow body of the sphere and what remains of the X attachment. We put the glue inside the cement, inside the hollow sphere, and then put all together, put all the pieces together. Clean all the excess cement before it gets hard, and then it's an aerobic cement, so it gets harder when there is no oxygen inside. So when it's completely covered, it gets harder. After that, you can reline your prosthesis, your old prosthesis, over this new abutment. So we have a very old implant with a very old and an old technique to place attachment, and we have a completely new attachment. Third problem that we can face is the consequence of usually the consequence of the unscrewing of the abutment, and is the broken screw. And if you don't have the solution, it's a very big problem, because the broken screw inside an implant could be a complete obstacle to make a new prosthesis over that implant. And if you don't have the instrument to put away that fragment, that implant is unusable anymore. And for the patient is a big loss, because it's a big loss of investment, of time, of patience, of money, of course. And the alternative is to cover or extract the implant, or cover and make it sleep this implant forever, and make another solution. But if you have instruments to extract this screw and reuse this implant, the patient will be very grateful to you. And now I introduce the kit, the broken screw extractor kit. It has one centering device, and this is designed for external hexagon and internal hexagon connection. You have also one hand piece, one hand driver, and you use it with your finger to drive the burr inside the implant. You have two kinds of burr. I'm just showing generically these components. We will go deep into the details very soon. We have two burrs. The first burr with two arrows, and the second burr that gets inside the screw fragment. So when you have a fragment inside an implant, when you have a fragment of a screw inside an implant, the first thing you have to do is to remove coronal aspect of the screw fragment. If it's broken, but one part is still inside the implant, you have to remove it. Then remove everything that covers the implant, so gum or other or calculus or tartar, and everything that cover the implant. You have to see perfectly what's inside the implant. So the access hole must be perfectly visible. Make hemostasis with laser, with everything you have, and then visualize remaining fragment screw. And the screw fragment. You have to visualize it. Where is it, and in which condition you find it. Then the first step is to take a probe, an explorer, and then attempt to remove it. You can see if it turns, if it's turning, if it moves or not, if it's completely fixed, because there are mainly two conditions. The first, when it's early, recent brokening, so the fragment is in the mouth since without the teeth, without the prosthetic components since a long time, since a short time. In this case, usually the screw fragment is easily removable because it lost the tension with the head of the screw. It has lost the tension, and so there is no obstacle to unscrew it. Otherwise, if the fragment is broken inside that implant since a long time, probably the saliva, the oxidation in the mouth, calculus, tartar, can stock the fragment inside the thread of the implant. And in this case, it's impossible to do it with Explorer. Then use the ultrasonic scaler, the thinnest tip you have mounted on your ultrasonic scaler, and then attempt to vibrate the screw fragment. Pay a lot of attention not to touch the thread of the inside of the implant, and try to confer an anti-clockwise movement to the fragment while you are vibrating with the ultrasonic scaler. If you are able to vibrate and you see some movement, then you can take again the Explorer, and then you can use once you have moved with the ultrasound, with the ultrasonic scaler. Yeah, it's better to use two probes, one in the opposite side of the screw fragment, and make an anti-clockwise rotational movement. If with the ultrasound scaler you are unable to vibrate, the only solution you have is to use the broken screw extractor kit. So you need this tool plus magnifier. You have to see exactly and perfectly what you have. I use 4.5 magnifier. It's enough to see what's inside the implant. Make a lot of X-ray check to see what's happening inside the implant. If the fragment is coming out or it's still stocked, if there is some damage in the implant. Then the most expensive instruments you need to use are time and a lot of patience, because a fragment stocked in an implant is it's easy to remove, but you need to be patient. It may require sometimes 1 or 1 hour and a half, the most difficult I extracted, So be patient, don't be in a hurry, explain clearly the patient what we are doing and what he is gaining, what is gain from this procedure. Let's get deep in what this kit is made of. So the centering device is designed for internal connection, internal hexagonal connection, or for external connection. It has a canal inside which the burr goes and rotates inside this tube. And this centering device allows the burr to stay perfectly coaxial with the implant. So it's impossible that your burr will touch the thread of the implant. Because it's perfectly fixed and coaxial to the axis of the implant. The first burr that we have to use is this one. This burr is designed to work anti-clockwise. All of the two burrs are designed to work anti-clockwise. So you need a counterpiece if you use the you need the handpiece. And it must be possible to set the handpiece to work anti-clockwise. And this burr must turn at very low round per minute. I use the implant driver device, and I use the speed that I use when I insert implant. So it's 5 or 6 turn per second, sorry. So it must be very slow because you have to give a lot of pressure to this, because it has to get a strong and tight contact with the fragment. This is an experiment we did with RAIN 83, just to clarify what's happening when you use it. And when you use the first burr, what you have is this. I explain more in detail. When I say that you need magnification system, I mean that you have to see the fragment, because you have to see the aspect of the head of the fragment. And as you see here, it's rough. It has not a smooth or polished surface, because the screw break like this, and so you have the metal texture after the fracture. And it's rough. You have some kind of roughness over it, and it's important because the roughness is what allows the two arrows of the first burr to clamp, to have the friction to move the fragment. And the first screw makes two jobs. First, impose to the fragment an anti-clockwise movement, and then completely flatten the surface of the fragment. You can see the difference between this completely rough and opaque, and this shining and shimmering because it's been polished by the first burr. I recommend you to go to the tube. I don't show you this video because you can find it easily on YouTube or on the RAIN 83 site. I recommend you to go to the site, the website, and there are exactly all the recommendations I'm giving. The only thing that I want to show you here is that when you use the centering device and the burr, both of the burr, they have several notches at this point. And when you turn it, when you make the rotation, when you make it rotating, you can see if you are extracting the fragment, you can see these notches rising out of the centering device. This means obviously that this is lifting up. Everything is lifting up inside the centering device. Okay, as you see here, inside the centering device. So it's another check that you can have that you are working good. So let's see some case. The first step is to use your finger, first of all. So as we said before in the algorithm that we showed in the beginning, first of all, we need perfect clean access to the implant. So all the obstacle outside, debris, gum, gingiva, or other fragments must be removed. And with magnification system, we need to watch the head of the screw to perfectly see the head of the screw. As you see here, it's perfectly rough. It's completely rough. And I hope that my first burr can grip the fragment easily. Then with my finger, I put the centering device inside the hexagonal, the internal hexagonal connection. And I have the perfect centering device centered in its axis, in the axis of the implant. And then I use the first burr with my finger, not with a handpiece. The first attempt must be this. So use my finger and this device that goes over the burr and turn it anti-clockwise, obviously, imposing a very strong pressure over it. And this is the first attempt. In this case, I passed to the broken screw extractor because my probe and my ultrasound scaler failed to remove to vibrate the fragment. So I passed the second step. And in this case, I was able to extract the screw just with my finger. A more complex case, the fragment is this one. This patient had this bridge in his mouth, and this is what I told in the beginning, the first slide that I showed you. In the future, we will have more and more patients like this. We don't know where he did this implantology. We don't know which country he made this implantology or this prosthesis. We don't know anything of this. They could be made in the 80s, 1980s, or 1990s. The patient hasn't got any certification, any documents of the implants. And so we have to start from this point. This is our point zero, and we need new instruments to take care of this situation. Claudio, I invite you to stop me to take a breath if someone has some curiosity or other. Okay.
Yes. I was mute. Yes, Gabriele. No, I just answered a question about the OTSM and about the cement
okay.
we can suggest. Okay. You can go straight.
Perfect. Okay. So the problem in this case was this fragment. This is a perfectly integrated, osteo-integrated implant. It's in the mouth since at least 30 years, as the patient said. But this one was this fragment was broken, I suppose, since a long time, because the prosthesis was still fixed, was not moving. So someone probably in the past removed and screwed it again. So this has been in this situation for a lot of months or maybe years. What I need is a complete access, a visible access to make the fragment visible. As you see, there is no bleeding, no gum interfering, and with magnification, I can check the position and the status of the fragment, the head of the fragment. I see the roughness that I need to check in the beginning. The first step that I'm skipping is to use the probe, then use the ultrasound scaler, and then if I'm not able to vibrate, then I use the extractor kit. And the first burr is the double arrow burr with my finger. But with my finger was not enough to remove the fragment. So I need to use the handpiece. And I made this X-ray to show you exactly how it works. So you can see the silhouette of the implant, of course, of the fragment, and then the centering device that fits perfectly inside the implant, and my burr that touches the head of the that touches the head of the screw. The first double arrow burr wasn't able to remove the fragment. I mean that the friction between the rough surface of the head of the screw, or the fragment, and the burr was not enough to remove anti-clockwise, to unscrew it. What the first burr did was not enough, but was a service for the second step, because it made the surface, the head of the fragment perfectly flat and perfectly polished. This means that the second burr that I insert inside doesn't take contact with an uneven surface, and there is no opportunity to have eccentric movement. I show you with the hand. If the head of the screw is uneven like this, and the second burr that has a very sharp point, goes over an uneven surface, it can go eccentric. But since I use the first burr that flattened perfectly the surface, the second burr perfectly touched the head of the screw with this sharp tip, and doesn't go eccentric, and make a hole exactly in the middle. Okay. And then after that, I can take an impression of this implant and use it again, putting new OT equator attachment. Another situation with an old central incisor. The patient came in my office, a new patient came in my office with this incisor in his hand. And I unglued the head of the screw was inside the crown. It was a cemented crown, so it has an abutment for cemented prosthesis, internal connection. And the first thing I did was to remove the crown from the abutment, and out of the mouth it's easy to do. It's impossible to do in the mouth, but out of the mouth it's easier. And then I had the head of the fragment. With the same procedure, I extracted the fragment inside the implant. I polished and sterilized the abutment, and I asked the company Rain 83 to make a replica of this fragment, and they produced me this. So I could be able to use the old crown, the old abutment, just changing the screw, putting a new screw. So with X-ray, I check that everything is the connection is perfect. With this X-ray, I check that the connection is not inserted completely inside the implant, so I need to push a little bit more to have a more tight engagement. And then after that, I checked the notches rising from the centering device. And with X-ray also, I checked that the fragment was moving out of the implant. Then after that, I waited. The patient had to wait 2 days that the companies milled a new screw for this. But the patient was very happy to wait without his central incisor, since he didn't have to pay. I didn't charge him with a new crown, a new abutment, and so on. And this is the final check. Everything is in its place, and this we renewed it with a cheap solution, cheaper than the alternative, this central incisor. Another situation, single implant. It's a lower arch with 6 implant with ball attachment. This attachment was very old. Was made in the 90s, late 90s, 1990s. And this was a non-standard Brannemark type of implant. It was 3.75 millimeters diameter. So I had to order a centering device for this, especially for this. As I said, remove all the coronal aspect of that covers the implant. And then this time I had to check the diameter of the hexagon. to have a customized centering device, especially for that patient. And I followed always the same steps, and let's say them together. First of all, magnification had a perfect visualization of the fragment. Second, use the probe, use the probe. Then use the ultrasound scaler. If I'm able to vibrate, then it's okay, and use again the probe, and unscrew the fragment. I wasn't able to vibrate the fragment, and then I had to use the kit. First of all, the double arrow burr with my fingers, it wasn't enough. Then the double arrow burr with the handpiece, it wasn't enough. And then I used the last burr. It wasn't enough to remove, the friction was not enough, but it made me the service to flatten the surface of the screw, the fragment. And then I used the last burr. It's designed to work anti-clockwise, and this burr rotate with more speed than the first burr. You have to use it anti-clockwise with 600 rounds per minute. So you need to stop frequently, to use a lot of irrigation to cool down to refrigerate for refrigeration, and you have to lubricate the hole inside, the tube, the canal inside, and make a lot of pauses. Otherwise, the risk is to overheat the implant and the fragments. And if you overheat the fragments, it's a metal part, and the metal, when you overheat the metal, it expands, so it gets more stocked. The friction, the contact begins more tight. So you need to stop and wash and rinse frequently, every 5 minutes or 10 minutes. This is what I said in the beginning, the algorithm. Be patient. Don't go in a hurry, because you must be slow. I use the probe, it doesn't move. I use the double arrow burr with the finger, and it doesn't move. It didn't move. I used the double arrow burr with the handpiece, and it didn't move. But I had the perfectly polished surface, as you saw in the first picture. Then I used the last burr with a sharp tip, and it produced a hole exactly inside the fragment screw. After you had this hole, the more the burr gets inside the screw, the more is the friction between the burr and the fragment. So there will come a moment when the burr will take all the fragment and move it anti-clockwise and unscrew it like this, exactly like this. With the X-ray, I check that, and there is nothing inside the implant, and this is the fragments. All the debris are produced by the drilling. You see, these are debris, metal debris, mixed with vaseline, because I used a lot of lubrication inside to avoid the friction. And then I produced a perfectly new, perfectly brand new spheroblock designed exactly for this Branemark implant. And we used exactly the same old processes without changing anything. And as you see, the fourth step, the last step, after you have removed the fragment, then it may occur, it's easy to occur that you will find an implant that you don't know what implant is that. So the last and the most important aspect is to treat unknown implants. And in the mouth of our patient, there are going to be lots more and more unknown implants. These kind of implants are from early 80s, but they are still in the mouth. And exactly this kind of implant in a patient of mine was the occasion that allowed me to meet the REIN 83 companies, because I had this implant. It was perfectly integrated in the bone. I didn't want to remove this, and my patient neither. And so the things that I could do was to take impression of the screw inside, of the thread inside, guess what implant is, guess what kind of screw and what kind of attachment we could make over it, and then make a completely new bar. And the most important thing is that my technician didn't know, completely didn't know what kind of implant was that. He doesn't need to know. So it's a very, if you know how to afford this problem, it becomes easy. If you don't know how to solve this, it's very difficult or impossible to use this implant. The attachment that REIN 83 has a strong compatibility with all of the implants you have in the market. I showed you that blade, Linkau blade, to provoke reaction, because it's the most weird and unusual implant that I found in my career. But the most common implants, it's easy to have in stock at REIN 83. It's easy to have equator attachment in stock for REIN 83. And now, after so much theory, let's try to solve this situation with a patient. Tomorrow, at your office, in your schedule, you find this new patient that is coming with this kind of problem. He has this bridge mixed with a fixed prosthesis, fixed over implant and fixed over teeth. I don't discuss about this. It's the previous dentist that made this, so I don't mind what he did. I just want to solve the problem of the patient. The problem of the patient was that she felt some movement. She felt that it was swinging. Especially not swinging, but it was popping out when he chewed, when she chewed sticky food. And she felt movement and started to feel some cold. I guess that there was an unscrewing that occurred, an unscrewing of this screw in the implant part, and this part of the bridge lost stability. The cement over this molar was lost, was decimented, or otherwise was decimented, and there was a small, very small movement that I can check, that I could be able to check with magnifier, because I saw some bubbles of saliva coming out when I pressed the prosthesis. Now, Claudio, can I ask you something? If we don't have so many participants,
we have 10 participants.
Okay, I would like to involve them.
Okay.
If you have a solution for this, where to start? Sorry, the last thing I have to say is that everything was completely fixed in the canine and incisor.
In the meanwhile, they will write in the QA. I will ask you, Edita asked, what kind of impression material you use when you have to know the implant, to recognize the implant. Okay. What is the procedure you do to recognize the unknown implant?
Okay, there are specific slides for this.
Oh, fantastic.
So I delay the answer for the next slide. Well, it's in this case, exactly in this case, that we will see which material and which procedure. Okay, if any has any idea on how to proceed.
I remember that everybody can write in the question and answer to intervene.
Well, where to begin? I summarize again. This is a bridge fixed many years ago since a previous dentist. And this patient came to your visit at your office, telling that she was feeling some strange movement from the backward part of the prosthesis. The movement was here, and she was starting to feel some cold. I checked that movement, and there was movement. With the X-ray, I can see a gap here, so I can guess that there is no, the screw is no more tightened. And with the hammer, I tried to remove this crown from this, but it was completely cemented. Okay. I go on. Okay, sorry.
If you,
I don't see
doctor, yes, Edita is starting to intervene, and
thank you.
is asking to open the crown
here
of the implant. Yes, you can read. Okay.
Perfect. Okay, it's not easy, Claudio. I ask you to read for me.
Okay, fantastic. Okay,
because I can't read.
Okay.
Okay, open here. Okay, that's good. I open here, and I can get to the hole to get access to the screw. Okay, I did it. And then I can see the screw. I suppose that I have the screwdriver. It's not easy to have it, but let's suppose that I have the screwdriver for this screw. I can remove this screw, and then that's right. That's good. A good starting point. How to go on? What to do now? I make another step. Another step is to cut the bridge and save the fixed part, the part that is still fixed. Polish it, so it's we pretend that it's another part of the fixed prosthesis, and then since we had removed this screw, we can easily remove everything from here. And what we find is this. An implant, we don't know what implant is that. And the project is to remove this, place a new implant here, so we can divide and make a separation between teeth and implant. That's my philosophy, not to connect implant and teeth and natural teeth together. Put another implant here, connect the old implant and the new implant together, and put another new crown, or use the old crown, cutting also this for the molar. Then what we have is this, but we have another instrument. So this is the fixed part of the old fixed bridge, perfectly polished as it is new. And we have the old implant. What we have to do is to put a new abutment for this. This is the old abutment, natural abutment. So what to do with a new unknown implant? We have this kind of shape, an hexagon and a 12 position. These are two hexagons combined together. And I take the impression of the inside of the implant. This is a gold screw, and this is the, I think that this is the healing screw, and the old dentists use it as a abutment, a cemented abutment, relined under the old bridge. It was a very weird and strange situation. And you see the 6 face of the hexagon, the 12 of the dodecagon, I think it's called, and the thread. Now, after there will be more slides on how to take the impression. what I need more is to give the company the cuff heights of the heights of the cuff of the gingiva, so 4 mm, and then they provided they provided me an equator, because I'm putting a new fixed prosthesis over the equator. I'm using the OT bridge equator solution. This is the equator with a nitruration. This is the new implants that I put after the uncovering. I use the two-step technique. So submerged the implant. The healing was completely submerged. After 2 months, I exposed the implant. I put the equator as it was an healing screw, a definitive and permanent screw. So the healing of the gum was perfect around the abutment. And the next step that I do are not touching anymore the gum. Claudio, sorry.
Yes.
Can you mute yourself, please? Thank you. Okay. Sorry, I had the echo inside my head. Okay, I didn't have the need to remove, so the impression was taken over the equator. I used these 2 plastic female cap just to cover the screw, or the thread of the screw. And after the healing, I removed the cap and took the impression. And then with this system, I want to emphasize the concept that I converted 2 implants with internal connection in 2 implants with external connection, because we converted them. And since this is a bridge and we have 2 fixtures, not perfectly parallel, we need we must to use an external connection, because they are not parallel. 2 implants are never parallel. The internal connection works good for single implants, but when you have a bridge, since more 2 implants, we have a bridge, and we need to use external connection, because when we take impression, impression with screwed transfer like this, we need to remove the impression without any distortion. What I mean is this: when we have 2 implants and they are not parallel among them, we put the transfer inside the connection. Okay, that's right. We put the screw inside the transfer, and then we splint together with resin or with the impression material. Then once it's hardened, we remove this system, but they are splinted together. It's a one piece now. And when we remove it, it's easy to produce a distortion of this movement of this transfer. And we don't know if it will come back in the exact same position. When we remove it, we need to make this movement. If we use an external connection, there is no problem like this. So this is why I used an external connection for a fixed prosthesis made by 2 implants, made by 2 fixtures. And this is the connection, the first check of the shade of the teeth, the shade, the shape, and the function, and the perfect fit of the components, of all the components. I check with the click of the equator system, and then the final day, the delivery of the prosthesis, of the fixed prosthesis. Once I have tightened all the screw, everything is fixed in its place. The old part of the bridge are perfectly polished and as they were new. Sorry, we made some conservative therapy in the abutment, in the posterior abutment, and then X-rays for the final check. As you see, I used the old crown of this patient. I re-cemented this old crown, and this is the old implant with the new abutment, perfectly healed, and the new implant with the new abutment. I just say here, I anticipate that I'm using the platform switch technique, thank you, Claudio, the platform switch technique and one abutment, one time technique. This gives me the advantage to have perfect condition of the soft tissue and hard tissue around the implant. Thank you. After that, with composite resin, I cover the screw holes and then fix everything. So I use this kind of system of fixed for fixed denture, for fixed prosthesis over implant. But I skip this since it's a long time. I think that we can make another webinar dedicated to this. And now let's focus on how to take the precision impression of unknown implant. First of all, you have to clean and rinse with hydrogen peroxide and microbrush. Everything, remove everything is inside the implant, of course. Hydrogen peroxide makes bubbles, and the bubbles come out. So, and the brushes move the most hardened debris inside. Then dry the inside of the implant with paper point, endodontic paper point. There must be nothing inside. Then use oil, Vaseline oil, for lubrication. And then dry all excess of Vaseline oil. Why do I use Vaseline oil? Because after we put the pin inside the implant, I need to unscrew it, and I don't want any friction between the impression material and the thread of the inside of the implant. So put some oil, some drop of oil, and then dry it, because an excess of oil can alter the shape of the threads. Then use a plastic pin for endodontic post, but you have to scratch, varnish, and varnish with adhesive, with the adhesive specific of your impression material. I use polyether. I use the polyether, but also polyvinyl xylosane are good. The most important thing is that you use the flow. The most flowable you have. It's exactly as you take the impression of the endopost space. So you can use a pin, then you can pinch it, you can scratch. I prefer to pinch it because after the hardening of the impression material, I impose an anti-clockwise movement. So I need a perfect engagement between the pin and the impression material. Then inject the light body impression material, polyether or vinyl polyxylosane. The most important thing is that you use the varnish, the adhesive dedicated to your impression system. And then insert the plastic pin. Move it like this, move it before you unscrew, move it like this, and then gently unscrew. What you have, unscrew and extract. What you have is this. This is the one that I used in the case we saw before. But you can take impression of other kind of connection. This is a Zimmer-like connection. And the most important thing that you have to record is the distance between two threads, at least two threads, the overall length of the abutment, of the thread inside, sorry, and the shoulder, which kind of connection you have here. Don't care about hexagonal connection or others, because since this is a rotating abutment, we don't engage any hexagonal connection. It's important if you have, instead, if you have a combination of both, I mean, conomorph connection and hexagonal, then the conomorph connection can be replicated. This is a little bit distorted here, but it doesn't matter because I have all the information I need. The overall length of the space inside the implant, the distance between two threads, and the shoulder here. Also here we have an hexagonal connection, but we don't need it. But the most important is that here we have the conical connection. This is still good, a little bit distorted. There are some scratch here, but I have the overall length of the inside space of the inner space of the implant and the distance between two threads, two or more threads, at least two. And this is enough for the company to produce an equator, a spheroblock, or a spheroblock for inner connection or for external connection. Or other components for that implant, like a single screw, like we saw in the beginning. I conclude, I finish my presentation. I thank you all for listening, and remembering that there are certification and patent pending on all of the components that I talked about. And I leave you with this image. I love mountain, and mountain taught me a lot. I quote Simone Moro. He's a legendary alpinist, Italian alpinist, that climbed the Nanga Parbat in wintertime. It's 8,260 meters. And he said, what he always says is that when you reach the summit, you have run only half the way. And how does it deal with our job? And what I mean is that when we finish the surgery or when we deliver the prosthesis, we are only half the way. Then start the descent, and the descent is the most dangerous part of the climbing. Coming down home safe is is where a lot of the accident occurs. So when having tools or to treat and maintain prosthesis in the long term is something unique that you can have and you can use with your patient. Thank you all, and hope to see you for the next webinar.